with a Doctor, featuring Southwest Florida's leading physicians, hosted by Dr. Gregory Leach and Jim York.
Good evening and welcome to Dialogue with the Doctor. I'm Dr. Gregory Leach and this is my co-host Jim York. And this evening we're speaking with Dr. Joe Gauta. He's a urogynecologist, a subspecialty in gynecology, which we need to learn more about. Welcome.
Thank you for having me.
Hey, Doctor, maybe you could just tell us a little bit about your background, your training, and your practice here in Naples, and how long you've been here.
Sure. Well, I was born in New Jersey, but I grew up in Punta Gorda, right up the road. Yeah, I went to high school there. And I went away for my training to Siena College and Albany Medical College in upstate New York. I actually was accepted to medical school out of high school, so I was accepted to both at the same time. I thought that was a great thing. I didn't want to pass that up. But it was so cold up there, I ended up doing my specialty training down in Tulane University in New Orleans. At the time, one of the premier OBGYN training universities in the country. And then I always wanted to end up back in Southwest Florida, so my wife and I came down here and started our family down here, and I've been here since 1998.
1998. And your offices, where they're located?
Well, my main office is on Immokalee Road in North Naples, across from North Collier Hospital. And we do have a satellite office out east at the other hospital, at the Physicians Regional Hospital.
You're solo practitioner by yourself, or?
Yes, well, I'm a solo practitioner, except that I have some people that I do work with. I have a physician assistant, and we have an entire team of professionals that assist me with the urogynecologic aspects of a woman's care. That includes physician assistants, certified registered nurses, and people that you might not see or hear about in some other offices because of the things that they do.
I'd like to learn more about urogynecology, and I'm sure our viewers would also, and I don't think it's a commonly used term, and I don't think people really understand what you do, so you're going to have to tell us.
Okay. Well, urogynecology is basically what it sounds like. I'm an obstetrician and gynecologist with extra training in the female urological or pelvic aspects of disease of a woman. Urogynecology has recently been certified as a board-certified subspecialty, just literally a couple of months ago.
Oh, really?
Yeah, so soon there will be board certification in this field, and I think its name will change to pelvic medicine and reconstructive surgery. But nonetheless, a urogynecologist is a physician, a gynecologist, who has specialized training in all of the organ systems of the female pelvis, including, of course, the gynecologic systems, but the lower urinary tract, the lower gastrointestinal tract, the nervous system, and the musculoskeletal system of the pelvis. A urogynecologist is uniquely qualified to take care of all of the aspects of disease and rehabilitation and treatment in the female pelvis. And it's important to remember the term female, meaning we only deal with women. The beauty of that is that we can concentrate all our efforts on the science of a woman's body, which is, fortunately or unfortunately, different than a man's. And so I do not do many of the things that urologists do, like prostate cancer or kidney disease. I do not do a lot of what the colorectal surgeons do regarding colon resections and diverticulitis, but basically anything else that happens in the pelvis is within my training and my expertise.
So you're not delivering babies anymore?
Correct. Yeah. As OBGYNs we do, but
right.
Yeah.
So for the benefit of our viewers, pelvis, can you just define for them what you mean by that?
Sure. A man and woman's abdomen is divided into two sections. The abdomen above the hip bones, above the bony parts of the pelvis is considered the abdomen, and below that and down to the area of where men and women urinate or defecate, that is the pelvis. So basically the pelvis is defined by the bony structure of the spine, the hips, and the bony parts of your hip here, including your pubic bone and all of the organ systems within it. That includes the lower aspects of the urinary tract, like the bladder, the urethra and the ureters. Those are the tubes that connect your kidney to your bladder. The anus and the rectum, all the nerves that go to those, the sacrum, the muscles that comprise the floor of the pelvis so that our organs don't fall out.
Right.
And all of the function that's associated with that. For example, the ability of someone to have sexual relationships effectively, or the ability of someone to have a normal bowel movement, or normal urination, or to be able to hold those things in place when wanted to. That's all within the realm of urogynecology.
So tell us a little bit about some of the things that you do or the things that you primarily focus on in your practice.
Well, first and foremost, I am still a gynecologist. So I deal with all of the traditional gynecologic aspects of a woman's care. Abnormal bleeding and its treatment, infertility, pelvic pain, menstrual cycles, menopause, and all those things associated with it. So as a gynecologist, we do assessment, we even do annual exams, female annual exams. But as a urogynecologist, we go beyond that. We go beyond the traditional hysterectomies or the traditional repair of a standard hernia in the vagina. We go beyond that in the realm of more advanced treatments, more advanced diagnosis. So, for example, my practice consists quite a bit of the treatment of different types of incontinence. Urinary incontinence, for example, is a big problem in women. It's a big problem in men too, but as a urogynecologist, I focus on women, and some of the diseases that occur in women do not occur in men. For example, the most common type of incontinence in women is stress incontinence, the kind of leaking that might occur when some type of stress is placed on the bladder. A cough or a laugh, or when someone jumps or dances. All of those things produce stress on the bladder, but a normally functioning bladder and urinary tract will be able to hold urine in when wanted to, and will be able to release the urine when wanted to. Some people don't have that ability anymore. I also deal in urogynecology with aspects from the rear part of the body. I'm trying to use appropriate terminology here so I don't offend anybody in the audience. But for example, the ability to hold a stool in when you want to is something that we take for granted. But unfortunately, there's a large population of women, about 1 in 13 women as a matter of fact, that have an inability to hold that in when wanted to. So for example, every time they urinate, they accidentally also defecate. Or if they're in public, they have to wear pads or even diapers because they can't hold the feces in from their rear end. It's an incredibly embarrassing situation, and up until recently, there weren't really good specialties or subspecialties tailored to deal with these types of problems. Colorectal surgeons did what they could, gynecologists did what they could, but now the emphasis is on treating these very highly problematic and socially embarrassing situations to improve people's quality of life.
Well, this is good because I can remember trying to determine in seeing a patient for problem 1, 2, or 3, a woman, well, which surgeon do I send this patient to? You know, a urologist, a general surgeon, a gynecologist. So you are the person that we send them to.
Correct. Yeah, and it's not that I know everything, but our ability as urogynecologists and our training allows us to do all the, to take care of all these aspects, but we also have colleagues that can help us in other situations. For example, not everyone's fecal incontinence is due to something in the lower GI tract. A thorough evaluation by a gastroenterologist is sometimes valuable to rule out diseases that can cause fecal incontinence, like, for example, irritable bowel syndrome or colitis or other things that you might have heard of.
Do people, is this a certain age group or a certain ethnic group, or is it a certain weight, people with weight problems, or is it, where do you see this, who has these common problems that you're talking about?
Gynecological problems occur mostly starting at the age of menarche, or whenever a woman has her first menstrual cycle. That's called menarche, sometime in the early teen years. But urogynecologic aspects of a woman's care usually occur, meaning the point in her life where women start to develop these types of problems are usually at the time of childbirth and beyond. Okay. It seems like one of the biggest triggers for pelvic dysfunction seems to be natural childbirth and some of the occult trauma that we are now learning about, that we are realizing is maybe much bigger than we once thought.
The trauma that occurs at childbirth, you mean?
Correct. For example, well, it's like women are delivering bowling balls. The baby's head is made of bone with some skin on it. Well, to a degree, that is malleable, but unfortunately it's still bone. And when other organs are crushed between the baby's bony skull and the mom's bony pelvis, those types of, those organs can sustain either permanent or temporary damage. It's the permanent damages that we usually deal with as urogynecologists. Now, that's not the only thing that causes these types of problems, but that seems to be around the age where I start to see patients. Those are usually my youngest patients, women that have already given birth.
So if you have a cesarean section, it does or does not eliminate the problem?
It doesn't eliminate the problem by 100%, but it certainly is protective. Now, there are things about pregnancy that we still don't understand, and we know that women who have all C-sections, as a matter of fact, women that have never had babies can still have these types of problems. So there are other risk factors, though the biggest does seem to be childbirth and pregnancy.
Multiple births, does that come into effect? Or
You
when
bet.
people say I've had a hard delivery, is that just, how's that affected? Or
Sure. I mean, the idea here is it's easier to deliver a golf ball than it is a basketball.
Okay,
Or it's easier to deliver one golf ball rather than 5 golf balls.
right.
So yes, you're absolutely right. The size of the baby, its position, what we do as physicians, meaning is the childbirth as natural as possible, or are we assisting the childbirth with assisted technologies like forceps or vacuum deliveries? All those things affect us. You're absolutely right. The quantity and the size probably of the baby being the most important.
So can you tell us a little bit about the treatment of the urinary incontinence problems that you were just alluding to?
Sure. Well, if you think about urinary incontinence in 3 major forms, you'll understand the treatments a little better. I already mentioned one called stress incontinence, and it is the most common in women. Again, it's the type of leaking that occurs when a woman puts a stress on her bladder, like a sneeze or a cough. Another type of incontinence used to be called urge incontinence and is nowadays lumped into a category called overactive bladder. It's a type of leaking that occurs when an urge to urinate overwhelms your ability to hold the urine in. Hence the term urge incontinence. That type of incontinence can occur at any age, and it occurs just as frequently in men as it does in women. And last but not least, the type of incontinence that occurs when a woman does not empty her bladder properly. That type of incontinence, sometimes called overflow incontinence or urinary retention, occurs because the woman doesn't ever empty herself. An empty bladder cannot leak, obviously, but a full one can. And you can use the analogy of a glass of water. An empty glass that tips over won't leak, but a full glass that tips over will leak a lot, and of course the spectrum in between. So the types of treatments are all very different for those 3 different types of incontinence. Part of what I do is to pinpoint, is to rifle into what is that aspect of a woman's problem, because the treatments are so different. Stress incontinence, the most common type, is most effectively treated with surgical repairs using a piece of material called a sling. It's not the only type of treatment, but this seems to be the most effective, and this has already been proven over decades of time and through multiple different societies like the American Urological Association.
We're gonna take a short break, and we'll get back and talk more about the sling and some other things that you have here.
Okay.
And we'll take a short break, and we'll be right back.
I had been a practicing orthopedic surgeon for a number of years, and I thought that I was invincible to the multitude of medical problems I saw around me every day. And when I received a phone call telling me that I had cancer of the prostate.
Dr. David Spellberg of Naples Urology Associates is the local specialist in treating prostate cancer with the new CyberKnife radiation treatment.
Once I got myself together was to do as much research as I could, and what I was looking for was a treatment that would give me the least risk of complications and side effects. And that's where the CyberKnife came into the picture.
Advanced CyberKnife technology, precise. It sends just the right dose of radiation to the cancerous areas, fast. Each treatment is only 1 hour, non-invasive. This outpatient procedure has almost no side effects.
The day after my treatment, I was out playing golf, and I'm looking forward now to continuing to enjoy a long and happy and comfortable life thanks to the care of my team of doctors and to the CyberKnife procedure.
Learn more about CyberKnife and Dr. Spellberg. Call today.
The survival rate for an early caught breast cancer is about 97%. Mammography saves lives by detecting that breast cancer early.
Radiology Regional Center, earning your trust yesterday, today, and tomorrow.
Radiology Regional Center is happy to bring you digital mammography. The advantages include shorter exam time, fewer retakes, and lower dose radiation. Radiology Regional Center, the best just got better.
Welcome back to Dialogue with the Doctor. Once again, we welcome another physician tonight, and we're speaking with Dr. Joe Gauta. He's a urogynecologist, and we're going to continue talking about incontinence treatments. And why don't you pick up where you left off?
Okay, sure. We were talking about stress incontinence, the most common type of incontinence in women. Typically, after the evaluation, we always do a thorough history and physical because 90% of what we need to know can come from that. But the treatments for stress incontinence include a wide range of treatments, all the way from exercises to what we call pelvic floor rehabilitation, which is very similar to someone getting rehab for a recently operated on shoulder or hip surgery or something like that, to these funny-looking things here called slings. These things called slings have been around for about 20 to 25 years. They're incredibly effective. As a matter of fact, they have about a 97% effectiveness rate in treating stress incontinence. The causes of stress incontinence are a dropped bladder or a weakening of the muscles around the urethra, frequently due to childbirth, which is what we talked about in the beginning of the show. These have absolutely transformed the field of urogynecology, and as a matter of fact, I think we're the impetus in our success and our ability to create a subspecialty around these types of problems.
So you were telling me earlier, just for the benefit of the viewers, that the only thing that remains in the patient is just the mesh part, none of this plastic, none of the blue?
Correct.
Okay.
Correct. The colors blue and the clear stuff here, which is basically like a saran wrap layer, are removed from the patient. The beauty of these slings is that they have an innate roughness to them, a bit like sandpaper. So they're not even sutured into place. They hold themselves in place. And therefore, these types of procedures, as a matter of fact, any procedures that I'm about to mention today, can all be done on an outpatient basis with as little recuperation time as 2 weeks of no heavy lifting. Mm-hmm. That is it. We encourage people that day to walk around, to go to the refrigerator. We have some patients that go to work the next day. I mean, these types of things are absolutely different than what people might know about from their mothers or grandmothers or aunts years ago.
So this other device that you have here, this
that contraption, that's a scary looking spider that we use for pelvic organ prolapse. Again, since we deal with all the aspects of a woman's pelvis, there are many organs that can drop, not just the bladder. I will talk a little bit about the other types of incontinence, but some of the things that can drop along with the bladder include the uterus or the rectum. These types of hernias can sometimes effectively be treated with things called pessaries, a medical treatment for prolapse. And you can think of a pessary very much like a pillow in a pillowcase. You know when you throw a pillowcase in a washing machine, it can turn inside out. Well, that's basically what some people's vaginas can do after trauma occurs to them. Well, if you put a pillow in the pillowcase can't turn inside out. That's the idea of a pessary. Put that in there, and with some routine maintenance, that can help people avoid surgeries for the lifting up of those organs. On the other hand, We lift up the organs very much like a hernia in the belly button. We can sew things back together again that are torn or broken due to childbirth in the hopes that these types of things will never fall again. In some people, their hernias are so bad or located in such areas that require extra support, kind of like the support on a guy's suit jacket here, or if anyone ever sewed their kids' jeans together and put a patch on their jeans, that's what these are. These are patches. And they attach to very, very strong ligaments in the pelvis that we think don't fail. And after childbirth, again, not everyone needs the strongest thing in the world. So these are not made for everyone. But these are made for people with particular problems. And this thing here, this thing you're looking at, this is a Boston Scientific product. This is the thing that some people might be hearing about on TV regarding the litigation associated with mesh. These slings have such a proven and wonderful track record. These are not at all concerning to physicians or to the FDA. But these things are rather new, comparatively. And there is some question about their effectiveness. Are they truly as effective as we think they are? We do believe they're very effective. But are they truly as effective as sometimes the companies that make them want us to believe? So that's what the FDA is looking into now. I don't think people should be afraid of these. In the right hands and for the right reasons, these are absolutely life-transforming. But they're not for everyone. They only work well when they're used in the right people. So this is one type.
So what you're saying is it may not necessarily be the product, it may be just how we use it or what patient we choose to put it in?
Correct. As a matter of fact, all of these products are similar in a way. They use some of the same materials and the same mesh size. I think a lot of what happens, a lot of the success that a patient might encounter comes from not just what we do, but how we do it, and fortunately or unfortunately, who does it. Meaning that a lot of what we do here comes from our experiences. I'm a professor or proctor or whatever you want to call that for a couple of leading industries, leading corporations in the industry. I teach physicians how to do these things. And it seems as though physician experience, surgeon experience, plays a lot into how successful the surgeries are and in the satisfaction rate that patients have.
So is this done on an basis as well?
It is, yeah.
And what does a patient expect? Are you using a laparoscope or are you making incisions?
Well, I don't do anything open anymore. There's no need to. And that's why everything can be done on an outpatient basis. Some of the things we do are laparoscopic. I do everything from one single incision surgeries called laparoendoscopic single site surgeries, literally a one tiny little 1-inch hole in the belly button, all the way to robotics, which can include 4 or 5 different holes in the belly and everything in between. But these types of things that we're talking about here are all done through the vagina with an incision anywhere from 1 to 2 inches. That's it. That's why the recuperation time is so fantastic.
So there's no abdominal incision at all with these?
As a matter of fact, most of the time we don't even enter the abdomen. We stay actually outside of the abdomen, only in the lowest portions of the pelvis. And people really, really do well.
Doctor, could you tell us a little bit about this little gadget?
Sure. It looks like a pacemaker, doesn't it?
Yes, it does.
And it's made by the same company that makes some pacemakers. The second most common form of incontinence, urinary incontinence in women, is what I had mentioned called overactive bladder. This little product is called Interstim. It's a sacral nerve modulator, the sacrum being the lowest portion of the spine back here. The nerves that come out of there go to the rectum and the bladder. That nerve is called the pudendal nerve, and this helps stimulate that nerve in a particular way to fix a person's particular problem. Usually, overactive bladder, urinary retention, or fecal incontinence. Again, fecal incontinence is that type of leaking from the rear end when people can't hold in their stools, or gas. Mm-hmm. That would be gas incontinence. This is made for fecal incontinence and urinary retention. This is also absolutely transforming in a woman's life. It's specifically used when other more moderate treatments don't work or cannot be done. For example, some of the medications we use for overactive bladder have some undesirable side effects. When people can't tolerate those side effects, or the person's problem is not in their bladder muscle, that's when Interstim comes into play. And this actually affects the bladder nerve. Now, there are other fantastic things we do for overactive bladder too. And it might sound funny to the audience, but we use Botox more than just for wrinkles on the face. We can inject Botox into the person's bladder muscle. Again, an office procedure, nothing fancy. But what it does is very similar to the wrinkles and crow's feet that people have on their face. It relaxes the bladder muscle. So when other more moderate treatments have failed, sometimes Botox injections into the bladder work marvelously. That also has about an 80% effectiveness rate. It's absolutely fantastic for such a quick office procedure.
Is this used on men too? Not to change the subject. Okay.
It is.
Just
as a matter of fact, it's used equally in men as it is in women.
Okay.
Because again, overactive bladder affects both sexes about equally for different reasons.
Right.
For men, a lot of times it's things like benign prostatic hypertrophy, BPH. In women, it could be other things like childbirth or nerve damage. But the point is that it works equally well. I don't do it in men, but the procedure is exactly the same in men.
I just wanted to.
Yeah.
And in terms of urinary incontinence, you talked about fecal incontinence as well. Can you address that issue?
Sure. And that probably is the most embarrassing situation that I deal with in a patient. Because as you might be well aware, it's hard enough to talk about urinary incontinence. But there's enough community awareness now where people are actually feeling open to the idea. Fecal incontinence, on the other hand, is debilitating to a person's life. And fecal incontinence is when you have the involuntary loss of stool. Fecal incontinence can be treated in multiple different ways, and we have about a 90% success rate in treating fecal incontinence non-surgically, and that's what we do. This is one thing we can use, but at the Florida Bladder Institute, which is my practice, we have the ability and the training to use all the aspects of the different types of care from different industry-leading corporations, and our own experiences of over 13 years of experience here in Southwest Florida to treat people individually and particularly, because everything that I mentioned tonight has one common factor, and that is that not one size fits all. Every patient is absolutely unique to us and requires a unique situation for the treatment of their problem. That's what we do at the Florida Bladder Institute.
So the Bladder Institute is a component of your...
It is, especially for women, is our general OBGYN practice, but my part of it, called the Florida Bladder Institute, is the part that I concentrate 100% of my time in, and this is all that we do. We don't take care of men. We don't deliver babies. We only concentrate on the diseases of the female pelvis and how to make our patients better.
And experience matters.
You bet. There are studies to prove it.
So,
At the end here, we're kind of wrapping this up. If you'd just like to tell people if they can contact you, where they'd like to contact you with the help.
Sure. Well, we have a website called floridabladderinstitute.com, and our phone number is 239-449-7979. We're there 5 days a week up at our North Naples office. We have the entire litany of diagnostic options for our patients, and you will see a doctor. You will see me.
Thank you very much.
We really appreciate you coming tonight. We learned a lot about what you do, and I think you're the only one around here that does it. So
Thanks for having me.
Thanks for coming.
Thank you.